Hi, my name is Diego Ruiz Dasilva, and I'm a dermatologist at Forefront Dermatology in Virginia Beach, Virginia. I'm also an assistant professor at the Eastern Virginia Medical School. Yeah, so I was really excited for our session this year. This is my first time directing a session, a topic that I'm very passionate about. So the whole concept behind it was identifying the ideal candidates and who aren't the ideal candidates, right? And at the end of the day, it's trying to contextualize the boxed warning that exists because I think most of us feel very comfortable with the efficacy of JAK inhibitors and oftentimes the superiority compared to the biologics for atopic derm and for other conditions as well. But the box warning kind of hangs people up a little bit and they don't know exactly where to use it, feel a little bit uncomfortable. So myself, James Song, Mona Shariari, and Chris Bunick talked about this. And the idea is this, is that the risk of MACE malignancy VTE in the population of an oral surveillance study was in rheumatoid arthritis in patients on tofacitinib, not specifically seen in the atopic dermatitis trial. So we went through a lot of both clinical trial evidence and real world evidence to demonstrate this and show how the broader pool of people who are appropriate candidates for JAK inhibition is much higher than most people think they are. Yeah, I think it is. I mean, if we take a step back, right, this is not brand new to us in dermatology. One of the oldest things that we've been using for a while now has been, tacrolimus or protopic ointment, right, which has this box warning from over 20 years ago. And I think patients kind of understand that has not been proven out over the years, and that is something completely separate in the oncology and transplant literature. And so they're very receptive. And I think we're getting more closer to that in our current oral JAK inhibitors for atopic derm and other conditions. But there's still a lot of progress to be made there. Yeah, so I mean, it's a really exciting time. I think historically, I personally was not excited about any of the orals for psoriasis. I just feel like they didn't work that well. And if patients really wanted a high bar of clearance and convenience, it just made a lot of sense with some of these newer biologics like 17s and 23s in terms of what they can do. But now with zasocitinib and icotrokinra, which we have already approved, I mean, you can get very high levels, very close to the most effective biologics. Somewhat rapid for an oral as well, because a lot of times in the past the orals are waiting 2, 3, 4 months to see major improvement. Within a month you can see it with either of these agents. And so I think it's going to be a time to explore that with patients, right? I think now we're finally going to know how common it is for people to really want an injection or want a pill, because instead of guiding people towards one or another, at least that's what I've done, just saying like, well, you might be a pill person, but this works so much better if you're willing to tolerate this injection. I'm truly going to let the patients pick, and we'll see, because I think that in my experience, at least in the AD world, it's pretty much half and half. Some people just feel like they're pill people. They already take other pills. They want to put it right into their regimen, right? And other people feel like they really like the convenience of taking a shot, 3 times a year, 4 times a year, et cetera. Yeah, I guess, right now I'm working on a paper on looking at dermatitis flaring as a side effect of the atopic dermatitis approved systemics at the 16-week mark versus placebo, and trying to kind of understand how we categorize this, what it means, what are what outcomes come after that, what patients need to be treated with, and expectations. Just so, I think as we get further along with so many treatments, it's getting a little challenging where we're like in this like microwave, we want immediate results society, and patients call back a month later like, oh, my skin's still rashy or it's still itchy, and can you switch me to something else? And I mean, we can, because we're spoiled, right? But eventually you can burn through everything. So I think we want to have like more information on how we should approach this and how we can counsel patients in the beginning of treatment.